We are looking forward to your talks.
Dr. Maria, Dr. Sudhir, and my dear colleagues, I am extremely grateful to the Indian Orthopedic Association for inviting me for this prestigious oration of the Well, sir, this is a zero research project, and I dug it out and zeroed on to the dollar and dollars in the form of gratitude of hundreds of my patients. I start with this Vedic prayer, O Lord, lead me from falsehood to truth, darkness to light, and death to immortality. Swami Vivekananda said, take up an idea, think of it, dream of it, until it is realized. It's golden jubilee of this, my tryst with the clubfoot, and I still hold on to it. Probably I'll continue it, and maybe till the platinum jubilee. From a humble start of a well-documented 100 cases for silver jubilee oration, my experience has enlarged to 1,000 cases in obstinate deformities during the last about 25 to 30 years. A complete metamorphosis of this concept has taken place during this time, and numerous innovative ideas for a total correction have been evolved. There have been many landmarks. A generic name of obstinate has been given to this deformity, a crisp name of dollar given to this surgical technique, and a terse name of dollars adding Z-plasty to the dollar has been evolved. A terse name of SSR given to the subtotal subtalar release, and evolution of an entirely evidence-based step-by-step correction has been evolved. A very important fact, a new version of this highly intricate 3D pathoanatomy, tibialis posterior being considered as the single most important factor, new thinking on equinus, predictability of triple orthodesis, and symptomatic genu recurvatum, many more new things. Every case gave an opportunity to think, and new ideas emerged every time to correct it. There have been numerous reports in the literature, but none has been entirely satisfactory due to incomplete understanding of the pathoanatomy. This term covers every possible rigid clubfoot. A sphere rigid, it is defined as a sphere rigid deformity at any age, not amenable to conservative treatment or other surgical techniques. It is classified into two major and two smaller groups. There are numerous factors responsible for obstinacy, complex pathoanatomy, and adaptive changes. These, we have no control over these, but the others can still be controlled. Early surgery in infancy is no good because there are large number of recurrences. It's very important to remember that each clubfoot is different as regards amount and rigidity of deformity, and the evidence is very clear even in the newborns. Different anatomical factors, different age-related adaptive changes, unusual other congenital defects will be described later. They reflect their own changes. For correction, a judicious pre-op assessment, planning, and meticulous selective use of various surgical steps is imperative, often additional ingenuity required at the operation table. Now, although founded on a detailed study of pathoanatomy in 15 deformed feet of stillborn compared with as many normals, yet newer interpretations have made surgery more evidence-based for a wider application. This is the classification of pathoanatomy studied in the specimens. Most humbly, I pay my homage to the feet of those 15 little angels who did not see even the light of the day, yet they immortalized themselves from the long forgotten divine existence in the closed museum jars by getting the 3D pathoanatomy and its interpretation unfolded for evidence-based step-by-step total correction. This technique has been used by me since about 40 years, and during the last 25 to 30 years, more than 50% were older children, adolescents, and majority were revisions. A good clinical examination and X-rays are imperative in each case. I don't operate before the walking age. Follow-up period varied from 6 months to 30 years, and in 600 feet it was more than 5 years. Briefly, various soft tissue releases in this extensive release are posterior, medial, subtotal, subtalar, lateral and stannular releases besides calcaneo-cuboid wedge resection, tarsometatarsal mobilization and talonavicular reduction selectively, of course. This is not a quick fix operation, but has some extra learning curve involving a judicious use of large number of surgical steps. To achieve the best results, there are two natural questions: cause of this common problem and the best treatment. A step-by-step evidence-based answer will be provided. Now, starting from the skin contracture, it's a three-dimensional contracture. It's very important and it is proportional to age. The evidence is very clear on passive manipulation. When you manipulate the foot, dorsal side becomes wrinkled and loose. On medial side, it becomes tense. Comparison of the surface area on the dorsolateral aspect and posteromedial aspects. A simulated two-circle diagram as drawn on the right side on this specimen is a proof which in one plane only. But as it is a 3D contracture and hence a 3D incision has to be evolved. Age-related and scar-related evidences are clear. A unique contracture will be described later. Therefore, it is mandatory to correct this contracture. Now, for this 3D contracture, an unusual 3D incision, that is dollar, a long curved hockey-shaped incision from dorsolateral to medial side, prolonged on the leg as shown. In most severe cases, dollar plus Z incision will be, Z-plasties added to this incision will be required. To avoid necrosis of flap, it is very important that a thick limited flap of 1.1 to 1.5 centimeter only is designed. For closure, it is imperative to place the first stitch at the right place. After estimating the rotation of flap towards posteromedial side, as demonstrated, dollar plus Z will be required, giving additional length on the medial side. VY plasty for a unique myofasciocutaneous contracture will be shown later. Now, these are the individual muscles, abnormal above and normal below. The difference is very clear. Abductor hallucis, now the muscles. Abductor hallucis is a small muscle, but it is hypertrophied and contracted, and it does contribute to varus. Needs sliding forwards. Gastrosoleus is evidence-based. The evidence is very clear in this. And you can see this is, the short, the muscle belly extending down as compared to the normal, and the evidence is clear in this specimen also. For correction, cutting the medial half from the calcaneum while doing Z-plasty is important. Tibialis posterior, muscle belly is hypertrophied, extends more distal. As you can see in this specimen, the most important single factor, and everything else can be explained on this basis. Age enhances the deformity. Evidence is provided by the 9 strong insertions pull the bones towards medial malleolus in 3 dimensions, whilst all soft tissues and bones follow. It can very well be compared to 9 tentacles of nonopus, which is an octopus variant, taking its kill towards the mouth, and also to the closed fist of the human hand, where all fingers are directed to the middle of the thinner eminence. Similarly, the tibialis posterior pulls all the bones and the bones become crouched up towards the medial malleolus. For correction, therefore, it is imperative to dissect and divide all insertions to open up the intertarsal and tarsometatarsal spaces selectively, of course. Plantar aponeurosis, flexure digitorum and long flexors, evidence is very clear in this specimen. For correction, Stanley's procedure, division of both long flexors at the knot of Henry, conjoint posterior capsule of ankle and subtalar joint. It's a very important part of pathology. It's a thick, short, continuous sheet of 3 ligaments as given over here. It's a major cause of incomplete correction, occult equinus as well as manifest equinus. 6-fold evidence is there, as you can see in this photograph. And the evidences are rocker bottom foot occurring while applying cilious prosthesis, break occurring at the weak point in external fixator treatment, genu recurvatum with clubfoot, reduced tuber joint angle in the lateral diagram, incomplete tendoachilles lengthening, resulting in occult equinus, which becomes evident on sitting on feet for ADL in India, and manifest equinus, which is even evident while the patient is standing, as is in this case. Even after complete division of the tendoachilles lengthening, the heel doesn't come down. So these are the 6-fold evidences for correction. Therefore, not only the tendoachilles, complete division of conjoint posterior capsule from lateral to medial side, opening both ankle and subtalar joints under vision is very important. This case was operated, tendoachilles lengthening was done probably somewhere at the age of 1 year. This deformity persisted because conjoint posterior capsule was not treated. Spring ligament, another important part of the pathology. In normal foot, it's a thick, wide triangular structure between sustentaculum tali and navicular, supporting the talar head and forming a significant part of talocalcaneonavicular joint. Under surface of the talus has 3 articular surfaces, 2 on the calcaneum and 1 on the 3 on the. Instead of 3 normal surfaces, spring ligament area is missing. You can see this is shown these 3 areas, and this is the spring ligament triangular, and in this deformed foot there are only 2 areas. This spring ligament area is missing. Talonavicular subluxation of this location. To explain it further, all surgical or the earlier surgical steps make the talus adequately free from calcaneum, but not completely, to allow requisite amount of correction. This is the concept of subtotal subtalar release, that is SSR, which is more than the partial release, which leads to inadequate correction, but it is less than complete, which leads to overcorrection. This is the middle path for optimum correction. A bonus of this subtotal subtalar release, besides restoring the space for spring ligament and increasing the medial length, it also closes the dorsolateral wedge from the, as done in the modified Evans procedure. Now, this dorsolateral hem on the is very important in the calcaneocubar area. It increases with age. Only soft tissue correction is ineffective in children above 4 years and even younger in very severe cases. Evidence is clear in dissections, scargram, and even intraoperative. Modified Evans procedure, that is excision of dorsolateral edge from cuboid and not the calcaneocubar joint as is done in original Evans, facilitates varus correction and also retains the calcaneocubar joint. Other adaptive changes. Equinus deformity is not simple as it appears. It's a complex deformity comprising 4 components, besides of course the occult and the manifest equinus, which I have already mentioned. Firstly, at the ankle joint, which is usually thought of. However, on deeper analysis, there are 3 more elements are there. Secondly, heel equinus, decreased talocalcaneal angle in the lateral X-ray due to talonavicular dislocation and conjoint posterior capsule. Thirdly, forefoot hindfoot equinus. As you can see, there is a 90 degree deformity at the forefoot hindfoot. Any one, two, or all 3 may predominate in the varying degree. complicated by other elements of inversion and adduction. Fourthly, an oversized talus vis-a-vis ankle mortis in sphere equinus of more than 20 to 25 years duration. Now, evidence, there is a six-fold evidence already given in the describing the conjoint posterior capsule, correction and predictability of triple arthrodesis. Colleagues, it's very important that only rigid and sphere, all components of deformity more than 20 to 25 years in an adult, if recurrent, will need triple arthrodesis only. All others can be corrected without triple arthrodesis. It's my firm conviction from this research that triple arthrodesis can be avoided in majority of adolescents and adults by a judicious approach, and I'll show you in the cases. Now, symptomatic genuine curvatum. It's a common observation that club-footed children walk commonly with hyperextended knees, even rotational alignment, without any symptoms. But I have seen two symptomatic cases which I will be describing. I'll now show some of the illustrative, very rare, rarest of the rare cases, of course, you see, which I am going to demonstrate. Without triple arthrodesis, and then with triple arthrodesis, symptomatic genuine curvatum, additional congenital defect, and dollar plus Z illustration. Now, this case, 13 years, corrected without triple arthrodesis, recurrent, you can see the scar of the previous surgery, and a very severe, you see, deformity corrected with this technique without triple arthrodesis. This 22 years female, again corrected without triple arthrodesis. Earlier, I had the impression that probably it is very difficult to predict whether triple arthrodesis will be required or not. But now you can predict it. This is 17 years operated in Indonesia without triple arthrodesis. This is 17 years, again no triple arthrodesis was done, and you can see the deformity well corrected and even occult equinus patient sitting comfortably on the feet. 35 years male, this patient you see was not bothered about the deformity, but he had bilateral fractures, both bones of both legs, and you can see the interlocking nails, and this deformity increased with this after these fractures, so he had to be this necessitated surgery, and this was treated, you see, with this technique with triple arthrodesis, and you can see, you see dollar plus Z scar on this corrected foot, and the patient having wonderful correction. Again, this is a unique case, rarest of the rare. The whole of the foot was only one bone. All the bone was fused together, extensive tarsal collision, inferior tibiopical fusion, and extrastosis, with a, you see, dense adherent scar on the medial side. First stage was only this dollar technique, partial correction, and then second stage, this is, you see, was done intertarsal fusion because you couldn't, you see, say it is triple arthrodesis, again dollar plus Z. This 18 years male, you see this patient had, you can see bilateral genuine curvatum with, you see, posterior subluxation of tibia, again treated without triple arthrodesis, foot was corrected, and not that the knee deformity has got automatically corrected. Now, this patient, again with genuine curvatum, and this deformity persisted for 11 years. The patient was not bothered until it, you see, the knee deformity appeared, and the gait was awkward, and the patient wanted corrected. They came for the knee deformity, not for the foot. The evidence is clear in this X-ray. You can see the scar of the previous operation, and as I told you, this is the, you see, cutting of the conjoint posterior capsule. You can see the talus jutting out between the subtalar and the ankle joint. That is what I mean by division of this conjoint capsule, and undervision cutting this joint completely, cutting this ligament completely. And you can see the patient sitting on feet. X-ray will show the posterior side opening up after you divide the conjoint posterior capsule. Now, this is a unique case. I have not seen such a case before. I don't know whether any of you have seen. This patient had absent metatarsal, flail toes, forefoot flexed plantarwards 180 degrees due to additional plantar myofasciocutaneous contracture. Now this was treated by a indigenous, you see, this soft tissue distractor which I just designed myself, got it made from a local workshop. It's a very low cost, light fixator and multi-part soft tissue distraction mechanism inbuilt. VY plasty of the plantar soft tissue was done in this case, and you can see the correction achieved in this case. Osteoglycosis, one side corrected very beautifully, the other side had recurrence at forefoot, hindfoot. A dorsolateral wedge resection at revision surgery corrected this deformity. Now this 7 years old female, extensive adherent scar after 2 surgeries treated by this technique, and you can see even the patient sitting on feet and the footprints appear normal. Now this is a illustration which I wanted to show, operated only 6 weeks back. Extensive scar all over, you can see, the scar on the posterior side, on the medial side, you see this is a bowstring, keloid, and on the plantar side, and even a ring, constriction ring at the ankle. And this was treated by this, you see, excision of the scars, and there are 2 Z plasties, you see this one and this one, there are 2 Zs. And you can see at 6 weeks, this is the correction and the child sitting on feet. Wonderful correction with such an extensive scar. This patient was operated only 2 weeks back. You can see the deformity. This is 22 years male, bilateral foot. I operated the more deformed foot, and on analysis I could predict that this foot will be corrected without triple orthodesis. And this is the, you can see the talonavicular, this is the navicular, this is the talus. Complete dislocation of the talonavicular joint, and this is the incision. These are 2 Z, you see, this is 1 and this is 2, incorporated in this dollar incision. And as I was telling, 9 insertion of the tibialis posterior. Very important, all the 9 insertions have been dug out from the sole of the foot, and you can count all 9 insertions in this, you see. You can see, you see, all the 9 insertions have been dug out, and this is the correction, and you can see Z plasties, wound beautifully closed, and the heel has come down equinus, hindfoot equinus has been corrected, only forefoot equinus is persisting. This will be corrected by a dorsolateral wedge resection without triple orthodesis in this patient of 10 to 2 years. And conclusion, take home message in this, all these have been already told, but some of them they do need, you see, emphasis. Equinus is a complex deformity. Correction of occult equinus is imperative for activities of daily living in India. Need for triple orthodesis can be predicted with proper, you see, examination and analysis of the deformity. Genu curvatum can be symptomatic and a presenting feature. Treat foot and not the knee. Long-term follow-up without any adverse effect proves its solid concept. Each clubfoot is different. Very important to remember. You see, no 2 feet can be similar, and they need individual attention. First, a very selective use of knife and meticulous use of knife. Lastly, 25 years back, I got Silver Jubilee Award for this work, and now the Golden Jubilee Award itself is an evidence of acceptability of this technique, evidence-based technique. While in Agra, you have to think of the Taj Mahal. Everybody exclaimed its beauty, but only a few think how difficult it was to build it. Started in 1631, 22,000 workers, 1,000 elephants, and for 22 long years. An old age saying, practice makes a man perfect, but man can never become perfect because practice never ends if you want to improve. My grateful thanks to all of you for your kind attention, and may God bless you.
Thank you, sir. For a moment, we'd like to present you the award.